So, good morning, everybody, and thank you all for being here with us today. It's really, really great to have this as the first session of the Health Data Forum Global Hybrid Summit. So, as you all know, the summit was supposed to be happening in these beautiful places we have in the back. And virtual does not mean distance, I hope.
So it's a fascinating time in Europe at the moment with a new commission and policies, especially around the European health data space and the EU for Health programme. Data sharing governance and digital literacy have an important role to play in the development of these new policies. The summit asks, how can big data empower health and healthcare for revival and renewal? This panel will start to answer that question. In my view, technology is often overpromised and under-delivered to healthcare professionals and citizens. I've seen a slide used by a couple of people that talks about the invention of the radio and how the radio was going to transform the delivery of care by healthcare professionals, just as an illustration of the point. So the question is, will digital and health data fall into the same trap of over-promising and under-delivering? The importance of data is clearly seen in the summit's agenda. There's AI, COVID, system architecture, interoperability, and EHRs on the agenda. The link to all is data and data access. At the moment, the pandemic is shining a very bright light on the use of data, analytics, and when data is not available, either in country or across borders. So as we were just speaking about before we started the panel, this opportunity presented by the pandemic, will it transform the use of health data?
Citizen secure access and sharing of health data, it is really a broader scope. And for us, it is very important that we take onwards the citizen perspective on this topic. Of course, it is very important to touch upon on the governance perspective and to see how can we identify and promote the adherence of digital technology and sharing of health data between the different stakeholders. We cannot forget an important uptake in terms to have data governance and data donation towards to have concrete data to be used between the different healthcare institutions, and of course to be reused by researchers, by public health authorities, and of course towards an innovation. In the end, we cannot do this if we don't look on the technical perspective, and we follow these interoperability standards, and we follow the flow of the data between the different healthcare organizations.
And that is that there are probably multiple answers to the question, because there's more than one first step to be taken. But I think there is an absolute prerequisite, which is that we are not going to be able to provide population-wide support for digital literacy without investment. And therefore, in a way, one of the very first steps has to be that agencies that have a responsibility for educating citizens, agencies that actually care about the benefits to all from more digitally literate patients, have to be ready to come up with the money. I know it sounds a bit blunt, but there are other actors, I would say, also need to be first movers, including patient organizations, educational bodies, public health bodies, many other bodies that would be closer to content or delivery, but none of them have spare budgets in their pockets today, especially in a COVID era. So we have to first decide that it's a worthy public investment, and that the people with some degree of control over budgets have to be ready to say, this is a priority. And it's not a competing financial priority with COVID. The opposite. It is actually a coping strategy for having COVID. because digitally literate patients will be better equipped to cope in a COVID era.
A step that can be done to do that is really to define what e-health competencies health professionals should have, and that should be designed in the medical curriculum and other healthcare curriculum from the first day in the medical school. Well, for me, one of the most important things is to begin with educating the professionals from very early on their career. I mean, even medical students should have a clear plan about digital health, because professionals can really be motivators for their patients to use technology and other tools. So the trust that the patients have in their doctors, nurses, or other professionals should be the motor to begin and to go on from that. The other thing is that the systems to health professionals should be born in the middle of the work and the healthcare providers. Health professionals need to understand that is something that comes to help them and not another tool that they should add on to their clinical work in their daily routines. So the professionals should be involved since very early in all the programming, designing, and so on of all the systems, so they can really feel that that is something that comes to help them, that is something that comes from real life, and this is not a battle between engineers and physicians or healthcare providers.
But I think it's an interesting point, especially if we consider this keyword of citizen-centered approach. What is citizen-centered in this content? Does citizen-centered mean the citizens should have the maximum level of decision? This would point to rather an opt-in system. Or does citizen-centered mean that the citizens in general should have the maximum benefit from the maximum amount of health data? This would point, in my opinion, more towards an opt-out option. Because, of course, if only data is contributed to a European health data space of people who consciously opt in, there surely might be some selection bias of people who are especially interested in the topic, especially well educated on the topic, living with some special conditions they want to know more about. So these are very interesting questions related to this, and I was very lucky to have these insights from our participants last week, who in the majority pronounced themselves in favor of an opt-out system where you would be a default contributor to a European health data space with your healthcare data.
Maybe what we are already doing, which is to say many times similar things or connected things in several different places is already a way to move forward. But for sure, it would be good to have a broader agreement between different types of stakeholders and to have some encouragement to progress on some more formal policy and bodies, as we were discussing before.
And we are becoming really a global hybrid summit. That's our goal. Yes, establishing bridge also between the US, Europe, India, and other regions in the world. It's really important because the world now is becoming a small, very small village. And if we had doubts in a few years ago, what happened in China would never affect us. So check out the streets and see everybody wearing masks. And that's the reason why we need to cooperate immensely. I fully agree with your conclusions, Vladin, and I would like also to point out here to show up the Digital Health Europe website, which is an incredible initiative that is the living proof of how the European civil society and even the European Commission, because in the end it's the European Commission that wants to have an active civil society, I think that probably the missing element we have now is the national government. So national governments needs to wait for a new reality, and that's what we here in the Health Data Forum are going to be able to offer this venue for you, civil society, researchers, practitioners. Please use our forum to extend your agenda into what needs to be done in terms of health data and our future.
Here which are really interesting. One is the ability of the citizen to actually manage their health themselves. They have a system called My Cancer. Again, this is the website. I would suggest you really do look at this. There's a lot to learn. They've been on this journey for a long time, but in essence, every citizen accesses their health records, adds to their health records, and really we have a situation where we have a really activated population. And the second thing I want to highlight is their use of the secondary use of data, a significant problem in all our jurisdictions, but they have set up an independent institute called FinData to manage this and manage it very well.
You know, we have an European community with many countries. But if I cross the border to Spain, it's our neighbor, my personal data is not available there. If I go to London on holidays, if I have a road accident and I go to the hospital, they don't know my allergies, they don't know my past history. Even if the data sets could be shared, there's no easy way to share data. And I always give the example of Visa cards. With my card, the Visa card, I can purchase any item all over the world. Why can't we understand ourselves around a common data set that can share with my identity card? The Portuguese identity card has a chip on it. It could bring my relevant data set to that health data set to that card, to that chip, and it should be read all over the world as a Visa card. I would like to raise another question. Is this in the best interest of the individual patient? There are a few good examples in Europe. For instance, the Estonians are doing a very good project that are already sharing information to other European countries, but the examples are so few that we know them one by one. Suzanne and says, no, we can standardize things, we can standardize data sets, we can all collect the same data and share the same knowledge. And that's very interesting for us doctors to learn from the same databases and compare them and benchmark them. And then you are starting the benchmark part of the project of Aisham. And I should congratulate Suzanne for the wonderful work Aisham is doing all over the world. In Portugal, we have several institutions that are not just using, but also contributing to the data sets.
It's been valued and marketed. There is actually an open trading market for that data, as you probably know, with secondary and tertiary uses of the data. What's never really been recognized is the person or the individual that generates the data. And that's not just health data, that's all data. What really needs to happen is that person who generates the data needs to be able to capture some of that financial value and use that. You know, the issue with that would be, great, so I give you money for your data. What do you do? Buy potato chips or you know, crisps or whatever, right? But what if that was turned back on itself to help pay for that person's healthcare? Yeah. I always think about the case of someone who has a rare condition that uses a specific specialty pharmaceutical that's very expensive, maybe 100 in the world. The patients like me model, which Daniel referred to, and I think it's still kind of going, is we'll take the data, but we will broker it and use it for clinical trials or research, and we'll use that to keep the lights on. I think that's a good model because it started in the mid-aughts, and no one had ever done it before, and most life sciences companies were against it because they weren't used to it, and now they have to deal with it because there's enough of a concentration of patients that have forced it into existence that now they have to deal with it. I would say that model works. I think the only other addition to it would be give some of those financial receipts back to the patients. Let them use it to pay for their care. I don't know how many stories of patients I've talked to that have been recruited for clinical trials where they will ask mid-trial, will this drug be something I can afford in the future? And the person who is giving the placebo or the control or the experimental arm says, I don't know, or no, I don't think so. That relationship has to change, but that's a fundamental change in the business model for most life sciences companies. And you can make the same argument for providers, for insurance companies. Insurance companies may not be so thrilled about it if a group of diabetics, for example, could manage their own condition, perhaps amongst themselves, go back to them and say, as a risk pool, we cost less, so give us a better premium, give us a better rate. You don't need to spend money. We will actually reduce the cost of business in your book. Just take us on. I would imagine for a large national healthcare organization, though, like the NHS, that might be an interesting model, the community model, and then giving the tools and responsibility of that community to manage it. That's my thought.
On this, because we're very engaged in this place at HIMSS. Technically, of course, we're running things like the Global eHealth Consortium with HL7 and all the technical bits. But this basically isn't about the technical bits, because the technical bits are the technical bits. What is much more difficult is the people interacting with all of this. And I think there are a couple of truisms here. One about data and secondary use of data. It is one of the most difficult subjects. And George, I hope I don't disappoint you, but the skepticism which exists in the United States exists in all major countries in the world. It may not necessarily always be governments they're angry about, citizens, but it happens everywhere. In a place like Japan, for example, people wouldn't dream of trusting the government with any data. There have been a couple of big data breaches, but they really trust Toshiba, Sony, and all the corporations. Now, isn't that very different to what we have in other countries? In the United Kingdom, the apps have failed miserably because people don't trust the fact that data will not be misused. There's no sunset clause when the apps were introduced over COVID. They're centralized rather than decentralized. There's all sorts of issues. And I like your comments as well about people owning the data, which is why I directed people to my Kanta in Finland and FinData, which is the institute, because it took 2 governments before they got to the stage. Actually, governments collapsed in Finland over debate in Parliament associated with the introduction of legislation around secondary use of data. We tried to do this in England and really came a cropper with care.net data a couple of years ago. The Australians really had a hard time as well. This is difficult stuff. It works very well in small places where there is that magic ingredient, trust. So what are the issues we really have to manage? Trust is the obvious one. In these countries, they've actually managed trust very well. The fact that approaches need to be tailored to the person rather than we think in terms of an app is for the whole population. No, it's not. We always think Gen Z. We need to think of all the population. And also the fact that precision health depends on really ongoing lifelong associations. This isn't about having a single intervention. This is a lifelong association. And you can't take what happens in Israel and plonk it in the middle of the Bronx in New York. It doesn't work like that. You need to understand the context of the society and the population to do that. Happy to have further conversations. I only have 10 minutes and I've kept to my time.
So as a summary, I think it's also important to state this is really the most intense single-minded focus research has ever done. And by this, I don't mean us, but I mean just science in general. This has never been done before in such a short amount of time. So much research is being done on this, and it's quite difficult to keep track of this information. And so being able to organize both the molecular and the patient data is critical to make progress, not just for this particular case, but I think going forward, I think this is going to be the future. Understanding how the molecular details, of course, better help us understand why some drugs would work, and combining molecular data with patient genetic and health records is likely to be a growing trend for the future in terms of health and treatments.
The European Commission also opened calls for projects directed to COVID in all areas, not only health data, which is mostly the focus of our discussion here, but here you can have some examples of how, in this case, projects that were already ongoing redirected their activities to tackle COVID-19. So the European Union, until September 2020, invested almost 500 million from Horizon 2020, the Research and Innovation Program, to fund projects that were ongoing and redirected their activities. And also, of course, new projects were funded. You have here some examples of the Project Eden, Conception. They are all online, Vaccines for EU. They are helping the European medicines agents to gather real-world data on COVID treatment and vaccines, and also Radar CNS that uses wearable technology and mobile devices to assess the impact of COVID-19 lockdowns. Again, I don't know the details of all these projects, but these are all available and currently contributing to the European response to the pandemic.
Us have seen increasingly how technology has come to our relief during the times of COVID. If you look at Taiwan, you know, this is a place which is like 850,000 people work in mainland China. They have a 23 million population, but what they used was merging the arrivals data, the immigration data with health insurance data, made it available to pharmacies, to hospitals, to healthcare providers. We're not surprised they just had 7 deaths and 530 cases, being still very close to the epicenter. So it was all about data being used to manage COVID. In India, we had 140,000 downloads of Arogya Setu, which was developed specially for COVID. The best part was that it helped us identify 3,000 hotspots. So we were able to warn people. I have an app. When I did this air travel, I need to necessarily show before entering the airport, which says I'm safe to travel. So we have used data, and this data has, I think, been coming handy for us to manage this pandemic. So you can see from my starting of the Kenya, where malaria, right till, you know, people using social media, us identifying where an epidemic or a pandemic is happening or a disease outbreak is happening, to allocating resources. It is all coming to data and collaboration. I think this is COVID has brought forth the reality that existed. We probably looked at not from an emergency perspective. That has brought, I think, world to agree to a point saying that it is a must-have. That is what my message was, and I'm happy to be a part of this panel and discuss this further. Thank you.
I do. Well, first of all, I agree with Pedro's point that I think that the scientific discovery is unprecedented, and it required global cooperation. And it, you know, the urgency, the global criticality of it was what was driving. But at the end of the day, if you think about it, data is a double-edged sword, because it gives us the ability to know, and the ability to know gives us the ability to create benefit. But it also is a significant issue around our notions of privacy and sovereignty. And this is what Rajendra was actually, I think, touching on. The challenge is that at an individual level, and you see this playing itself out in live time around issues like contact tracing, right? Is as a society, public health has always wanted to know who has a disease in the interest of the public. And there's always been this challenge of the individual feeling stigmatized about whether or not anyone knows that they have the disease, and the public's desire to know in order to mitigate the disease. Now that we can collect that information passively, that just makes the situation worse. It doesn't make it better. It doesn't help the individual who's fearful of stigma. A live example in the city that I live, something as simple as the ability to tell first responders, if they were a fire or ambulance, if police, if they're arriving at a home, that there's a COVID positive person in that house. The legislature basically created an ordinance that said that they need to know. And the executive for that geography reversed the position and said no. Why? Because they were afraid that they wouldn't get any responses if the fire or the police knew. And technology just made the ability to know that passive, which made the problem even worse. But it was a political and a social problem. And we see the same issue going on right now around agency. Healthcare is fascinating because at the one level, we as humans, our biologies are the same. It knows no national boundaries. But every country considers the health of its population to be a sovereign asset.
On behalf of the World Health Organization, the Regional Office for Europe, during the next few minutes is a short presentation. I will go over 3 topics. So first, I'll do a very brief data reality check, in particular considering the wider effects of the COVID-19 pandemic. Second, I will go over some reflections on how we can overcome this situation, just some personal reflections. And finally, I will touch on some key priority actions that the WHO Regional Office for Europe is planning to develop in the framework of our recently approved European Programme of Work 2020-2025. So let's begin with a data reality check. Next slide, please. So as you may know, in September 2015, the 193 United Nations member states agreed on the 17 Sustainable Development Goals. From these SDGs, 12 goals, 33 targets, and 57 indicators have been identified as health-related SDGs. So in this map, you can see the availability of data to inform global health-related SDG monitoring. So unfortunately, as you can see in this map, the availability of recent underlying primary data is uneven. So for most countries, and recent primary or underlying data were available for between half and 80% of the health-related SDG indicators. For almost 1/5 of countries, however, over half of the indicators have no recent primary or direct underlying data. So for example, according to one of a UN report, some countries in Africa and Asia, on average, have data available to monitor only 20% of the SDG indicators. So this clearly shows that significant gaps exist in the availability and quality of data to inform global health-related SDG monitoring. Many national health information systems require urgent improvements, starting with not only greater investments in human and technical resources, but also in interagency collaboration. So strengthening health information systems is a core priority for WHO to ensure that countries have the basic needs to work in the digital age. Next slide, please. Another important fact, this one connected to the COVID-19 pandemic, is that along with the work of health workers, data are a key tool to effectively tackle this pandemic. So during these unprecedented times, I have had the opportunity to lead response teams on the ground, and I have seen firsthand that data are more urgently needed than ever to inform critical interventions. So in particular, to learn about the epidemiological situation, healthcare capacities, including health system functions, public health capacities, and availability of effective pharmaceutical interventions. Data are also needed to determine multi-sectoral and non-pharmaceutical measures, such as lockdowns or temporary suspension of socioeconomic activities. And finally, to monitor the wider effects on population health, because this pandemic and the actions taken to control this virus have an impact on population health beyond the direct morbidity and mortality it has caused. The range of these effects is broad and include, among others, disruption of health services and social, economic, and psychological impacts. Despite the progress achieved using digital solutions, the power of data has still not been leveraged. So now, of course, we have learned a lot from this pandemic. So for example, it has reiterated that real-time data and effective integration of different data and information systems can facilitate effective, timely, and data-driven decisions. It has also highlighted the consequences of a lack of health data standards, a delay in receiving data, a lack of integration and interoperability between different data systems, and an insufficient number of trained people to properly manage and use data. So in this first part, I just wanted to highlight the importance of robust data and the current challenges and data gaps that countries are facing, even when there is political commitment at the highest level. Next slide, please. So with this data reality check in mind, we now move to some ideas that countries should consider on to address these barriers in the context of the new normal. So this is the current situation. As you know, COVID-19 pandemic has not ended yet, and until there is an effective vaccine or treatment, everyone remains at risk. So we all need to work together to protect ourselves and others. So in the context of data in particular, we also need to consider this new normal. And for this, I would like to just suggest some principles and steps. So first, as key principles, we suggest 4 actions that member states should agree to be successful in mitigating the health, economic, and social impacts of COVID-19 and beyond. So these key principles are: facilitate data comparison and secondary use of data, enhance the monitoring surveillance systems, also exchange relevant data, and finally promote a data-driven culture to allow that everyone is able to access, use, and manage data. And if we want to be successful in executing these principles, there are 5 steps that member states, countries should work on together. So first, to establish a high-level data coordination mechanisms in charge of implementing a data governance strategy composed of multi-stakeholder partners. Second, to define data flows and processes which could be manual or digital. So not everything is digital. So also having good processes documented, even they are manual, is super relevant. And third, to adopt data standards to facilitate integration, interoperability, and forecasting at the national and the global level. So these first 3 steps are critical to success, and every country should move in that direction. The next 2 steps that I'm going to propose are equally critical, but will depend on the availability of financial resources. So the first one is to invest in data and digital technology because it is essential and will facilitate the automatization of different data and measurement processes. And according to the Paris 21 Partner Report published last year, international funding for data and statistics is only around half the level that it needs to be, which means that a lot of work is still needed on that end. The last step is related to empowering citizens, since everyone needs to understand the rights, the benefits, and risk of sharing data, especially related to ethics, privacy, and security. So the implementation of these ideas will lead us to an environment where political decisions are data-driven. Next slide, please. Countries are not alone in this journey. So to achieve these recommendations, countries can, of course, rely on institutions such as the European Commission, the OECD, or us, WHO. So in our case, the WHO Regional Office for Europe, I am pleased to inform you that 1 month ago, ministers of health and public health leaders from the 53 member states of the European region endorsed a new 5-year vision, the European Program of Work, that we call EPW, that it will be in place from 2020-2025, that sets out how WHO Europe and its member states will work together to meet citizens' expectations for health, including strengthening data and health information systems. So under this program of work, under this EPW, and in regard to health data, we are committed to developing big data capacity in surveillance, modeling and policy monitoring, also developing a European health data governance framework through a European health data governance charter, and complementing classic data collection by robust use of big data, online surveys, consensus panels, and experts' opinions. So in particular, these actions will help us address the recommendations made by the 194 WHO member states during the last session of the WHO Executive Board that was held in May. So from a data point of view, these actions will contribute to reducing data fragmentation and the reporting burden on countries. It will also enhance the capacity of data systems and increase data availability. So the question is, how are we planning to do this? So first, with you, with your collaboration, and in close coordination with key partners, such as the European Commission or the OECD, and other international organizations such as the World Bank, by setting up a new data team considering the new normal. Second, by reviewing the available evidence, something that we are currently doing in the fields of big data and artificial intelligence, and for which we expect to show some results by the first quarter of 2021. And of course, by making this evidence available to decision makers to facilitate investment and adoption. And third, by providing technical support to countries on the ground. So if we work together, we are convinced that it is just a matter of time before we will be able to provide the right data in the right place and at the right time to leave no one behind and make a measurable difference in people's health. So, and with this, I conclude my presentation. Thank you so much for your attention. I look forward to any question or comment that you may have. And in addition, my email is on the first slide of this presentation, so please feel free to reach out to continue this conversation. Thank you so much.